it. It's my sister's birthday. Well, good morning. Good morning, all. I know we have folks still filtering in, but we'll go ahead and get started with announcements and introductions. Welcome to Medical Grand Rounds. As a reminder, next week we will be hearing from the cardiologist Cheyenne Huang. Her talk is entitled Medical Neighborhood 2.0, Why Should Specialists Care? Today we are joined by Dr. Sarah Hopkins. She is a practicing endocrinologist with PMG Endocrinology on the East Side. She earned her medical degree from Columbia University, did internal medicine residency at Mount Sinai School of Medicine in New York, and then came back to the Northwest where she did her endocrinology fellowship at OHSU. Dr. Hopkins, in addition to her busy clinical practice, has stayed engaged with research efforts at OHSU and is a generous and talented teacher, continuing to lead small group teaching at OHSU, and is increasingly recognized for expertise in the community, invited to give local and regional talks. We super appreciate her joining us today to discuss osteoporosis.
Great. Thanks for having me. It's nice and dark in here. Can everybody hear me okay? Okay, great. Well, again, thanks for having me. It's good to come home. I was actually born at St. Vincent's Hospital, so it all comes full circle. So today I'm going to be talking about osteoporosis, and I have nothing to disclose. My goals for today are really to kind of emphasize the conversation I have with patients to address their questions and address the questions they may be bringing to you, and tie in kind of the clinical literature that supports what we do and how we can emphasize why we're doing what we're doing to the patients. So we'll briefly review screening recommendations and why, and how I talk to patients about that. Review a little bit and emphasize the importance of the workup for secondary causes of osteoporosis prior to initiating treatment. Focus on common questions that probably all of us receive regarding treatment, including what about calcium and vitamin D? What's the optimum amount of each? What type? What are the risks of the medications, and how do these risks compare to the benefits? How do we know if a medication is working? How do we monitor therapy? How long will I need to be on the medication? And what comes next if the treatment that we start with doesn't work? So common things that probably come up in your clinical practice. And again, I'm going to do this all from the perspective of kind of working through probably a typical case that you may all see. And so this is a 65-year-old woman. She has no significant medical history. She's here for an annual exam. She's very active. She eats a healthy diet. She has no history of fractures. And she wants to know, do I really need a bone density right now? And so when I talk to patients about their bones, I like to just educate them about what is normal bone health. What does the typical cycle look like? And just to review, we have several phases in a healthy bone cycle. We have activation of the osteoclast through the Rank ligand receptor, and this is the point at which denosumab works to inhibit proliferation of the osteoclast. The osteoclasts then work at the surface of the bone to resorb bone, and this is where bisphosphonates work to inhibit bone resorption. On the bone formation side, we have activation of osteoblasts, and this is where our PTH analogs act to activate osteoblasts. And we have mineralization, so calcium and phosphate deposition to hardening the bone. And then this is our sclerostin activator down here. This is where the new agent romosozumab acts, and it ultimately leads to both increased bone formation and decreased bone resorption. And so what I emphasize to patients is that in healthy bone, there's a constant balance of bone formation and bone resorption. And early in our life, we accrue bone until we hit peak bone mass around the age of 30 to 40, after which, both in men and women, there's a gradual decline in bone density. Of course, this is accelerated at menopause with change in estrogen potency, and we know that over time there is decline in bone mass after age 30 to 40, ultimately leading to a change in bone architecture, which leads to decreased bone strength and increase in risk of fracture. So clinically, what does this mean? Unfortunately, up to 1 in 2 women will suffer an osteoporosis-related fracture, and up to 1 in 5 men. And that's where the recommendations for screening come from. Now, there are several different screening recommendations out there, but these are from the National Osteoporosis Foundation and the American Academy of Clinical Endocrinology. So kind of widely accepted in the United States is to screen all women age 65 or greater, postmenopausal women under the age of 65 who have an additional risk factor for osteoporosis, such as hyperthyroidism, steroid exposure, anyone who's had a fracture after the age of 50 to get a bone density test. And they also advocate for screening all men over the age of 70, and similarly men under the age of 70 with additional risk factor. Of course, can we get this paid for? So this gets to the question of what are the recognized Medicare coverages. So Medicare coverage is limited to postmenopausal women, people with chronic steroid use, long-term use of osteoporosis medication, vertebral abnormalities suggestive of osteopenia, osteoporosis, and primary hyperparathyroidism. And specifically in men, there's no universal screening strategy that is recognized by the USPSTF, but the National Osteoporosis Foundation, American College of Physicians, and Endocrine Society do all recommend universal screening age 70. So you do kind of run into a barrier when you're kind of trying to click the diagnosis coverage, if you can get that covered. So there's still a lot of advocacy behind this in figuring out the optimal screening strategy in men. So back to our patient, she agrees to a bone density. Her screening bone density shows that she has a T-score at the femoral neck of negative 2.8 and negative 2.4 at the spine. Again, she's had no history of fractures. So what does this mean? So this is when I think it's important to take pause and understand that not all low T-scores equal age-related osteoporosis. And this is where it's really important to stop and think, could we be missing something that would be the preferred treatment strategy rather than rushing someone to a bone-specific medication? So of course, big things to think about are, could this patient have osteomalacia? Could they have severe are they someone at risk of vitamin D deficiency, low calcium intake? So we'll talk about getting a dietary history briefly. And a few that I'd like to highlight that are often under people's radar are the possibility of something called hypophosphatasia. So luckily, typically we do have CMP panels on patients, and if you have someone that's had a chronically low alkaline phosphatase level, it's possible they have hypophosphatasia. And it's really important to recognize this because those patients already live in a state of low bone turnover, and so you would not want to use the typical osteoporosis medication such as a bisphosphonate that decreases bone turnover further. It would place those patients at increased risk of fracture, and particularly atypical femur fracture, which we'll touch on later as well. So that's a big one. You have that number probably at your disposal, or when you get your, they don't have a CMP because they haven't been seeking medical care regularly, it's easy to get. And then of course, the other one emphasizes metabolic bone disease and chronic kidney disease, and I'll put a plug in at the very end of my talk, but for CAMR rounds in September, you'll have a visiting faculty person that's going to touch on this more. But with Prolia being available, or denosumab being available and not metabolized by the kidney, so obviously you can use it with people in EGFR less than 35, so I've seen that often the reflex is if, oh, they don't qualify for bisphosphonate, we should put them on denosumab. That's not always appropriate, right? People with chronic kidney disease can have many different forms of bone disease. They can have adynamic bone disease, where again, that's a state of low bone turnover, and a bisphosphonate would be harmful. They can have severe osteomalacia due to not converting vitamin D to the active metabolite. And so this is often, when I see referrals for this is a conversation I like to have with the nephrologist, make sure I've done appropriate assessment of their PTH, phos, calcium. But unfortunately, the only way to know 100% what the underlying bone disease is in CKD is a bone biopsy, which I learned very early in my practice is not available. So it's our best educated guess, honestly, and she'll talk a little bit more about that, looking at what is the phosphorus level, what is the calcium level doing, PTH balance. But these are patients that we should give pause before just reflexively putting them on denosumab if they have a low T-score. That's not the whole picture. And then, of course, in your post-bariatric patients, they could easily have secondary hyperparathyroidism due to calcium malabsorption, or have a young woman with severe Crohn's disease struggling to just get a vitamin D level above 5. So obviously, those would be the things you'd want to address before considering bone-specific therapy. And then endocrine disorders, so hyperparathyroidism, hyperthyroidism, Cushing's disease, hypogonadism. If you have an obese patient with osteoporosis that's not responding to therapy, it is prudent to check a 24-hour urine cortisol. So, and then anorexia nervosa, multiple myeloma. And then, of course, many medications have been associated with decreased bone density. And, of course, some medications are associated with increased fall risk. So back to our patient. Again, she's pretty unremarkable. She has some mild GERD symptoms. She has no history of fractures, no history of kidney stones, which is something I do ask everyone about, no history of thyroid disease, which I always ask. Family history, again, of course, we're always asking about hip fracture to calculate a FRAX score. No family history of osteoporosis. She's not on any medications. She doesn't take any calcium or vitamin D, but she gives us a history of getting quite adequate amount of calcium through her diet. So she eats 2 servings of dairy daily. And on physical exam, she hasn't lost significant height. Since her peak height, she has no kyphotic or scoliotic changes or spinal tenderness, and she stands with ease, good balance, and gait. For screening labs, this is what I typically get. So a CBC, specifically I'm looking at the hemoglobin. If there's evidence of anemia, I'll consider testing for multiple myeloma. Again, in the comprehensive metabolic panel, I specifically am looking at creatinine. Again, if it's elevated, I'm thinking, could this be related to the CKD, or should I screen for multiple myeloma? ALK-Phos we talked about. If it's low, I'm concerned for the possibility of hypophosphatasia, and then usually the next step is actually to get a vitamin B6 level. And then calcium, looking at, does there any history of hypercalcemia, suggestive of possibility of underlying primary hyperparathyroidism, or hypocalcemia, which obviously has to be pretty severe, something abnormal going on to actually have a truly low calcium level. Always get a phosphorus, because there can be phosphate wasting diseases that can either be genetic or acquired, particularly in the setting of malignancy. And often the phosphorus isn't included in our CMP, so I'll screen back to see if there's been one of those in the recent past. A vitamin D level and a TSH. And then if there's something suggestive in the clinical history, such as a history of a kidney stone, I will get a 24-hour urine calcium. Or if I'm really worried about malabsorption for either history of bariatric surgery, I'll get a 24-hour urine calcium to see if it's very low, or PTH to screen for secondary hyper or primary hyperparathyroidism. And then, anemia, CKD, hypercalcemia, consider a UPEP-SPEP. So we do all that for her. There's nothing to suggest she has a secondary cause of osteoporosis. So what can we tell her in terms of recommendations? So these are the standard universal recommendations. So calcium intake for women over 50 should be to target 1,200 milligrams daily, men over 70, 1,200 milligrams, and then men under 70, 1,000 milligrams daily. The standard vitamin D for most people that's adequate is 800 to 1,000. Weight-bearing exercises, fall risk assessment, and then smoking cessation and avoidance of exercise. I'm going to spend a little bit avoidance of excess alcohol. I'm going to spend a little bit, not avoidance of exercise, spend a little more time on the calcium, because I get a lot of questions about that. Everyone's bringing their bottles of calcium in. There's all sorts of different, marketing out there of different calcium with different additives. So what's best? And also, there's a lot of concerns about, I've heard calcium supplements are bad. They cause kidney stones and they cause cardiovascular disease. And so clearly patients are worried about their health and they want to know what's best. This is a very busy slide. I'm not really going to go through it, but basically it's just to show there have been many meta-analyses. When I was researching for this, there were all these different meta-analyses that had very different results. So there were some suggesting increased risk of cardiovascular risk, some suggesting no proven association, some with increased risk of kidney stones, particularly at super therapeutic levels. But basically the takeaway is that we know that calcium and vitamin D are important for bone health, and we know that deficiencies in these are associated with poor bone health. But calcium and vitamin D, they may lead, some of the studies suggest they may lead to moderate fracture risk reduction, but not significant. The benefits of calcium and vitamin D supplementation are clearly greatest in those patients at highest risk of deficiencies. So people, with underlying GI illnesses, poor absorption, bariatric surgery, and nursing home patients. So not your typical community dwelling patient who's out in the sun. And there's insufficient evidence to prove that calcium supplementation targeting a normal level increases the risk of cardiovascular events. And then what calcium? Should I do carbonate? Should I do citrate? Do I do magnesium? Do I need zinc? All these things are targeted towards patients trying to pick the perfect calcium supplement. So what do I tell patients is don't overdo it. There's clearly no benefit to getting above the 1,200 milligrams recommended daily amount. Figure out what you're getting through your diet. So an average serving of dairy has about 300 milligrams. There's actually a nice .smart phrase in the Providence system that's like osteocalcium, and it prints out what foods have how much calcium in it. So I usually print that out for patients. I say, kind of calculate up what you think you're getting in a day. If you're clearly short of the 1,200 milligrams, you can supplement to get to 1,200 milligrams. But overdoing it probably just increases your risk of kidney stones, and there's this question about cardiovascular risk. If you can do it through diet, that's the best because it's most easily absorbed, and there's been no proven association when people have high dietary calcium intakes, and if anything, it's actually shown benefit with reducing cardiovascular outcomes. And then in terms of which calcium to do, calcium carbonate is the most cost-effective, so it's 40% elemental calcium versus 20% in calcium citrate. And so if you want the fewest pills possible, you're going to get your biggest bang for your buck in that way. And then vitamin D, what's the optimal vitamin D level? Institute of Medicine says 20, National Osteoporosis Foundation says 30. The whole idea is what vitamin D level prevents the rise or secondary hyperparathyroidism. And probably it's around the level of 20, but if we're targeting 20, some people may end up at 15, so the National Osteoporosis Foundation says let's target 30. Most people will then end up around 25. So, yeah. So patient asks, can't I just focus on calcium, vitamin D? Do I really need a medication? I feel great. So what can we tell this patient? She's kind of already been doing everything right? She's getting good dietary calcium. Her vitamin D looked normal on the screening test, and she's already getting regular exercise, and she has good balance. And unfortunately, she still has a T-score of less than -2.7. So bumping up her calcium intake, increasing her vitamin D is really unlikely to be of additional benefit in preventing her fractures. So this is when we can talk about who are candidates for therapy. So someone who has a history of a hip or vertebral fracture, T-score of less than 2.5 at the hip or spine, and a T-score of -1 to 2.5 with a predicted risk of fracture over the next 10 years of 20% for a major osteoporotic fracture and 3% for hip fracture at 10 years. So aren't the medications dangerous? I've heard they cause fractures. So this is where we can kind of go through the patients. What do we know about the medications? So first, we'll talk about the benefits. So we know that there's effective fracture reduction. We'll review some of the data, but kind of throwing all the agents together is about a 50 to 70% risk reduction in risk of vertebral fractures, 40 to 50% in risk of hip fractures, non-vertebral fractures 20 to 35%. The fracture reduction occurs early in the treatment course. You don't have to wait years and years of being on treatment to have that benefit. There's relatively low risks, which we'll go through, and then we'll talk about duration of therapy and treatment response. So this is a table just kind of lopping all the anti-resorptive treatments together because clearly these are typically our first-line agents due to cost and efficacy. But looking in this middle column, again, this is our vertebral risk reduction, so alendronate close to 50%, Reclass 70%, denosumab from the Freedom trials 70% or 68%, and hip fracture, again, 40 to 50%. The number needed to treat is quite favorable, 14 to 20. for reduction or prevention of one vertebral fracture and on the order of 90 for preventing a hip fracture. Important to note that abandronate did not have statistically significant risk reduction for hip fracture. So that's notable, but might not want to use that one. And then fracture reduction is effective very early in the treatment. So looking again at the initial clinical trials, so this is the FIT trial looking at alendronate, and we see within 6 months of treatment, there's separation from the placebo and treatment arm with regards to onset of hip fracture. This is also seen with zoledronic acid. So again, within 6 months, there's separation of these lines, placebo and treatment arm. And then denosumab, similarly, there's separation clearly by 6 months, placebo from the treatment arm. And then just obviously, bottom line, what's the cost difference? So looking up acquisition costs, you can get a lot of different numbers from a lot of places, but clearly alendronate is the cheapest, and everything I found for reclass and denosumab was on the order of about $1,500 to $1,800. And this was a study that was also including like administration costs and the infusion, as well as clinical costs of administering the injection in clinic for denosumab. But isn't alendronate dangerous? I've heard it causes fractures. So of course, you've probably all heard there's been a decreased uptake in use of bisphosphonates over the last 10 to 15 years, and that's mostly because of this concern for atypical femur fracture. So we'll talk about mostly spend time talking about atypical femur fracture, which has a proven association between risk and prolonged use. There are clearly some risks that we know about, or side effects that we know about, that have nothing to do with how long you've been on the medication. So GI upset with oral bisphosphonates, flu-like symptoms with IV, and then hypocalcemia and bone pain. And then without clear causality includes atrial fibrillation, osteonecrosis of the jaw, and I'll have one slide on that. But to spend the most time on the atypical femur fracture, so clearly people have femur fractures, at risk of that for osteoporosis, but these are unusual fractures. They're low trauma, subtrochanteric or femoral shaft, non-comminuted, and they're transverse or short oblique in orientation. And one clinical factor is that they often have a prodrome of symptoms of dull thigh pain, so something you can educate your patients on as well. And we know that it's associated with prolonged use of bisphosphonate. There have been reported cases in Prolia. We'll talk a little bit more about the rates of that. And then we know that risk factors include female sex, Asian ethnicity, and again, the hypophosphatasia, osteomalacia that we talked about at the very beginning. So if you can pick that up early, you may avoid putting those patients, exposing them to increased
frequency of the fractures?
Yep. Next slide. Okay, so atypical femur fracture. So this was a cohort study put out by Kaiser. I guess it was 2012 now. It looked at 12,000 patients with a femoral fracture. 142 were deemed to be atypical. 10% of those were in people who had never had bisphosphonate exposure at all. And then they looked at what was the risk of fracture based on how much bisphosphonate exposure there had been. And so for people with 2 years bisphosphonate exposure, the risk was 1.78 per 100,000. At 5 years, that rose to 20. And at notably 8 to 10 years, that was up to about 100. So clearly with prolonged use, it increased. This, with all the concerns out there, this group decided to try to put out or estimate what's the number needed to treat to prevent one fracture versus the number needed to harm to cause one atypical femur fracture. So it's a little bit confusing, but I'll walk you through it. But this data is from the FIT and the initial alendronate and zoledronic acid trials. So again, these numbers should look familiar from what we talked about. Number needed to treat was 14 for prevention of vertebral fracture, and then non-vertebral 35, and hip fracture 90. And then they converted that into number of events prevented per 1,000 patients treated for 3 years. And so any fracture basically prevented 100 fractures per treatment of 1,000 patients for 3 years. Then down here, they're trying to calculate the number to harm. So over on the left is the hypothetical relative risk of atypical femur fracture. So this is number per 100,000, so kind of coming from that Kaiser data, right? So they used, what if it was 1.2, which would be kind of lower than any of the numbers we saw there, What if it was 1.7, which would approximate the risk that was seen for patients with 2 years exposure, and maybe 11 or 12 would approximate the 10 years exposure, right, that was reported on that previous slide. They then transfer that into a number needed to harm, and so clearly the number needed to harm far outweighs the number needed to treat, which we can reassure patients. And then the number of atypical femur fractures associated with treating 1,000 women for 3 years, clearly there's a big difference. So you're 100, I guess you could say at 10 years of treatment, you're 100 times more likely to suffer a fragility fracture than an atypical femur fracture on treatment. And clearly earlier in the treatment, when the fracture rate is much lower, that benefit is even higher. So, and then very briefly, osteonecrosis of the jaw is extremely rare. Phase 3 clinical trials have extremely low incidence rate, not in excess of placebo. Risk factors do include poor oral hygiene, steroid exposure, and chemotherapy exposure. The American Dental Association put out a position statement basically saying this should not be a key factor into whether or not you're going to initiate treatment in your patient. Concern for osteonecrosis of the jaw shouldn't be the principal concern. It should be whether or not they're at high risk of fragility fracture. Now, practicality-wise, if you have someone, they're about to get a dental implant and you're about to initiate, they haven't suffered a recent fracture where you're feeling like you really need to expedite something and they had a screening bone density showing osteoporosis, there's not clear guidelines on what we should do in that case, but many people feel it would be reasonable to delay therapy for a few months until there's adequate healing of the implant. But even in the Endocrine Society guidelines, it's very wishy-washy because we don't have good data on what to do in that situation. So you elect to try alendronate given the low price and efficacy at the hip and spine. So she wants to know, how do we know if this is working? We're starting this new medication. How do we know if this is working over time? So what is the annual follow-up? So typically review risk factors, make sure the creatinine is still appropriate to continue bisphosphonate therapy, review adequate calcium, vitamin D intake, and weight-bearing exercises. Get an accurate height assessment. That's an easy thing to do. And if there's been 2 centimeters or greater of loss in the interval, you should consider vertebral imaging to assess for vertebral fractures. And then the big question is, at what point do you get another bone density? So the American College of Physicians recommended against getting a bone density in the first 5 years of treatment. This was considered low quality or weak recommendation, but this did prompt a response from National Osteoporosis Foundation and ACE, suggesting that they really did emphasize the bone density should be started 1 to 2 years after initiating therapy. And the big reason is that you want to identify individuals who are not responding to therapy. Those individuals may, again, have an underlying secondary cause of osteoporosis for which it's harmful and not appropriate to continue them on a bisphosphonate for 5 years. So we're not necessarily expecting their bone density to improve, but if there was significant decline, you may want to take pause and redo that assessment for secondary causes before continuing them or committing them to treatment. So 2 years later, back to our patient, her height has declined 2.3 centimeters since starting treatment. Her bone density demonstrates some improvement in the T-score. A spine x-ray reveals a new compression fracture at T12. So should I stop the alendronate and start something else? So what defines a treatment failure, right? How do we decide, oh, this isn't working, let's switch to something else? We know we can't prevent all fractures. Vertebral fractures, we can prevent 50 to 70% risk reduction. But so the National Osteoporosis Foundation came out with a set of guidelines of what is considered a treatment failure. And that included 2 new fragility fractures after 6 months of treatment. So again, it takes 6 months for those placebo versus treatment arms to separate. So if they fractured within 3 months, we wouldn't really consider that a treatment failure. Or 1 new fracture and a significant decline in bone mineral density. They do also outline the possibility of using markers of bone turnover, but I don't use those, and some people do, but you have to do them at baseline and then watch for the change. So I'm not really advocating for that. But basically, 2 new fragility fractures or a new fragility fracture with a significant decline in bone mineral density. So with her, she's had 1 fracture, and her bone density improved, so we continued on treatment. 3 years later on alendronate, she's had no further fractures. Her height is stable. Her T-score at the lumbar spine is -2.3 and femoral neck, -2.7, so still in the osteoporosis range. So she's asked, isn't it safest to stop the drugs after 5 years of treatment? So duration of therapy. So the American College of Physicians guideline, or American College of Physicians recommends stopping therapy after 5 years. And then ACE and the National Osteoporosis Foundation recommend duration of therapy should be individualized. So we'll talk a little bit about what we know about long-term therapy with these medications. So key considerations, we know there's continued benefits with regards to fracture reduction with prolonged therapy. We know the benefits decline after stopping therapy. And for individuals most at risk for fractures, the benefits do continue to outweigh the risks. Oh, this kind of came out really funky. But basically, I can walk you through what should have been on here. So this was the extension of the FIT trial. So that was, again, alendronate versus placebo. And then those patients who were all on the treatment arm, so first 5 years of alendronate, were then randomized either to continue therapy or to switch over, or stop therapy, basically, switch to placebo. And what it showed is that there was still a significant reduction in risk of vertebral fractures out to 10 years of treatment, and those patients who continued versus stopped treatment. And the number needed to treat to prevent one vertebral fracture was 32. So in that extent, the second 5-year arm. And there was no significant change in the risk of non-vertebral fractures in the initial analysis. But then they did a post-hoc analysis stratifying the risk of non-vertebral fracture based on what the T-score is at the time of then randomizing to continuation of alendronate versus not. And what they showed is for patients who had a T-score of negative 2.5 or below, so osteoporosis at the hip, there was still a 50% reduction in non-vertebral fractures. So suggesting certainly there's risk, benefit with regards to decreasing risk of vertebral fractures up to 10 years, and there is risk of reducing non-vertebral fractures in those patients with the lowest T-scores, or T-score less than negative 2.5. No benefit when the T-score was negative 2.0 or greater. And then this is looking at the Horizon extension trial. So again, this represents patients who received 3 years of zoledronic acid, then followed by placebo, versus 6 infusions of zoledronic acid, and it showed the odds ratio for a new vertebral fracture was 0.45, so significant reduction out to 6 years, and they actually did extend that out to 9 years, and there continued to be fracture reduction benefit. They did not comment. This was, they didn't stratify in the same way in terms of non-vertebral fractures based on the T-score. So next, so we know that there's continued benefits in terms of fracture reduction long term, and then what do we know about what happens when we stop the medications? So this, again, looking at alendronate, and then this is the data for zoledronic acid. So for the FLEX trial, which was the extension, again, this is your initial, everybody who's on alendronate, then they're randomized to either placebo or continuation. And what you can see is there's a significant drop. This is bone mineral density change, so this is not fracture data, but it showed there was significant loss of bone density as soon as 1 year after treatment was stopped, essentially. And then similarly in the Horizon extension trial, so this is the first 3 years of treatment with zoledronic acid, followed by transition to placebo versus continuation of therapy. And at 18 months, again, looking at bone mineral density, there was a decline in bone mineral density by 18 months off treatment. So we do know that with stopping therapy, there are changes. Again, this is bone mineral density data, but we also had the fracture data suggesting there's benefit over time. But we talked about the atypical femur fracture, so we know at 5 years of bisphosphonate use, the risk of atypical femur fracture is on the rise. But it still remains low, and based on that number needed to treat versus number needed to harm, you still need to, you're still going to prevent far more fractures by continuing therapy versus just stopping therapy altogether. So should we switch to denosumab at this point? She's had 5 years of treatment. Should we transition to denosumab? So this is looking at long-term treatment of denosumab. This is the Freedom trial. So over here, this is new vertebral fractures. This is non-vertebral fractures. Green is the placebo arm. So the trial was 3 years of either randomized to placebo versus denosumab, and clearly there was a significant reduction in the risk of vertebral fractures. Again, that was on the order of 70% versus placebo, and you can see there's the rate of vertebral fractures continues to be significantly lower than seen in the placebo arm out to 10 years. Of course, they did not continue the placebo arm once they found that there was such significant fracture reduction benefits. That wouldn't have really been ethical. And then in the non-vertebral fracture arm, similarly, they saw there was a significant reduction in non-vertebral fractures. And when they mapped this out, they actually found there was a statistically significant relationship between fracture risk reduction and time on therapy. So it seems like the benefit even accrued the longer the patients were on the denosumab, which is different from what we see with the bisphosphonates, where there's kind of you still have the fracture reduction, but it's a little bit of a plateau effect. And more recently, they put out a paper looking at, that's interesting, is there really additional benefit the longer you're on denosumab? So they stratified patients who'd been on denosumab for 4 to 7 years and compared the risk for fracture at 4 to 7 years of use of denosumab versus years 1 to 3. And they found that there was additional reduction in non-vertebral fracture rate for even patients with T-scores, I guess, as high, depending on how high, low is always a little tricky with T-scores, but of negative 1.5 or below. So with the, again, with the alendronate, the non-vertebral fracture benefit seemed to be limited to those patients with a T-score of negative 2.5 and below, whereas this study suggested the denosumab fracture reduction benefit may be seen as far as patients with all the way up to a T-score of negative 1.5. So it'll be interesting over time to see if there's a treat-to-target approach with osteoporosis there. We're not there yet, but we may be moving in that direction, according to Dr. McClung. And then in terms of the relationship between atypical femur fracture and denosumab use, in the entire Freedom trial, Freedom Extension trial, there are only 2 cases of atypical femur fracture over 10 years. The adjusted incidence rate was extremely low, and there's no proven kind of association by prolonged use and incidence of atypical femur fracture. So it does appear to be different from bisphosphonates in that way. But what do we know? So we know with bisphosphonates, if you stop therapy, you have reduction in bone mineral density maybe at 12 months to 18 months. But with denosumab, it's immediate. So the way denosumab works, right, is it prevents proliferation of osteoclast activity, decreases bone resorption. What we see when patients stop denosumab is there's an immediate uptake in bone resorption, which is illustrated by rapid decline in bone density. So the upper arm is just patients who were initially randomized to denosumab and then continued on denosumab, and then what happened with their bone mineral density when they stopped it. These were patients initially randomized placebo, followed by transition to denosumab, and what happened with their bone density when they stopped it. So very rapid decline in bone density, and this was kind of followed by or preceded by case reports of patients who had spontaneous vertebral fractures with stopping denosumab therapy. So this was not foreseen when it came on the market. But again, this is due to rapid reversal of the bone osteoclast activity. And we know now, there was a study, I didn't put a slide in that about this, but there was a study this year called the DAPS study, which basically showed what happens when you transition from a year of denosumab to a year of alendronate, because that's what has been recommended, but there was no study really showing if that was effective or not. And it did show that the majority of patients maintain the bone density gains. However, the patients who seemed to have the greatest decline were those patients who had the greatest benefit on denosumab. So there was, we'll be learning more about that. But so far, recommendation is if you're considering stopping denosumab, and again, at what point you should do that still remains a little unclear, you need to follow it up with something else to prevent that risk of fracture. And that something else should only be a bisphosphonate. And so it's tricky if you have a patient with EGFR less than 35, right? What do you do? So that's tricky. And so the takeaway is that fracture reduction occurs within months. Fracture reduction persists with long-term treatment, so up to 10 years. And then risk increases when therapy is stopped. So with denosumab immediately and bisphosphonates within years. And I guess the other big question that we're hopefully going to be learning more about is, does a drug holiday, how much does that reverse the risk of atypical femur fracture? There have been some studies suggesting 2-3 year holiday can lower that risk, but we still don't know a lot about that question. So because of everything we kind of went through, the National Osteoporosis Foundation does recommend duration of treatment should be individualized based on a patient's risk. After 3 to 5 years of treatment, risk assessment should be performed again. And then if there's a modest risk for fracture, consider a treatment holiday. High risk of fracture, so those patients who have had a fracture or they have T-scores less than -2.5, or other additional risk factors like steroid use, then you should continue therapy or consider an alternative. So back to our patient, and this was a while back, but she ultimately elected to continue alendronate due to the low cost and knowing that she was tolerating it well and the benefits seemed to outweigh the risk of atypical femur fracture. At 7 years of alendronate, she fell and suffered a left hip fracture. Her bone density was unchanged. She reported taking the pills weekly. So now she's had 2 fragility fractures on alendronate. So going back to those National Osteoporosis Foundation guidelines, 2 new fractures on treatment would be considered treatment failure. So we repeated the evaluation for secondary causes of osteoporosis. So whenever you're thinking about transitioning therapy or someone's failed therapy, that's a time to, again, just reflect, are we missing something in the picture here? So we did that. There was nothing to suggest we were missing something else. So what are our treatment options now? Should we switch to an IV bisphosphonate? There's still fracture benefit out to 10 years like we saw, but, I showed you the 6-year data, but there is data out to 9 years. But we know the risk of atypical femur fracture is increasing. Or should we switch to denosumab at this point? Or should we consider something like an anabolic treatment, teriparatide, abaloparatide, or the new romosozumab? And so this is looking at women who had 2 years of oral bisphosphonate use and T-scores of less than -2.5, transitioned to either denosumab versus zoledronic acid. This is not fracture data. This is looking at bone mineral density data as a surrogate. But what we see is that there was, in terms of change from baseline, there was greater benefit in the denosumab arm as compared to the transition to reclass in all patients, which probably isn't too surprising given she'd been, for her and for our patient, we think she's been adherent. We don't have concerns about absorption issues. So probably if you're more in the patients you're concerned, are they really taking it? You could consideration of transition to IV formulation could still be a benefit. But should we consider a bone building drug at this point? So a few key points that I want to just highlight. I know these aren't, we don't use these very often, but it's good to be familiar about when we think about using them. So what do we know about these treatments after bisphosphonate use? Because our standard patient is coming to us, initial treatment with bisphosphonate is appropriate. But in which patients should we consider these agents as a first-line treatment? Obviously, cost is a huge issue, contraindications, and then follow-up. So this is a study looking at teriparatide, so PTH analog, versus risedronate. It's called the Vero trial. The plan for the comparison wasn't that everyone had to be on a bisphosphonate prior to randomization to one of these, but 57% of patients had been on bisphosphonate therapy prior to randomization. So I still think this gives us valuable information about can there be benefit to transitioning to teriparatide with regards to fracture reduction after bisphosphonate use. And this is one of the few kind of head-to-head trials we have for fracture data, but it does show there was significant decrease in the risk of vertebral fractures after 12 and 24 months in the teriparatide versus risedronate arm, and time to first clinical fracture was reduced. So it suggests there is still benefit. So, often people say, well, the greatest benefit of using a PTH analog is as initial therapy followed by an anti-resorptive, but often that's not an option, right? Someone's already been on a bisphosphonate because that was appropriate first line for them. So would transitioning to PTH still be a benefit? And this suggests it could be. And then this is looking, the structure trial. So this specifically was at women previously on oral bisphosphonate for at least 3 years, transitioned to either romosozumab, again, the sclerostin inhibitor, or teriparatide. And it showed, again, this is bone mineral density data, so not fracture data. But it showed at the femoral neck, obviously there was much greater benefit in the romosozumab group, and actually there was some decline at the 6-month mark that then seemed to get back to baseline in the teriparatide group, and then greater benefits seen in the lumbar spine romosozumab use is limited to 12 months, so we don't, and they didn't extend the trial out, but it suggests there's greater bone density gains at the hip and spine. And kind of giving me pause about teriparatide in a person you're mostly concerned about risk of hip fracture is there was this decline in the bone mineral density there. But then, what's the sticker price? So again, looking at different sources, but some estimates for teriparatide were up to $38,000 a year, but it seems, I think this was from UpToDate, these are acquisition cost estimates. So they're all pretty similar, teriparatide, abaloparatide, romosozumab on the order of $20,000 a year. And romosozumab, again, is limited to 1 year of use. The other two are limited to 24 months or 2 years of use.
Medicare coverage?
So for the teriparatide, I haven't actually tried to get romosozumab approved by anyone. I don't know if you have. Yeah. So I'm not sure. The teriparatide, often if they've failed, other treatments, you can get partial coverage, and then usually we'll have to go through like a medication assistance program. But if there's no assistance, then I haven't had patients initiate it. But actually, majority of my patients have been able to get approval. What's your experience?
I think even patients who get some coverage, the patient's portion of the coverage often winds up being several $100s. And for many of our patients, that's
Right.
too much, even if it goes from 20,000 to 800 or 900. So
Yeah.
it's a big issue.
And for denosumab, typically Medicare covers 80%, and then sometimes additional supplemental insurance will cover the difference there, but so at a minimum, patients usually have to, or they'll at least, they may have to pay up to $220 per injection is my experience, but often a lot of the secondary insurances will cover that. But reclass is obviously, fully covered, so a big difference. So who would we consider anabolic therapies as first line? Again, cost is a huge, huge issue, and I always bring that up with patients. But again, I have had some luck with medication assistance programs where patients have paid nothing. So if I really feel like someone's at very high risk of fracture and would benefit from the therapy, I'll usually go down that road to look into medication assistance programs for them. But so patients who have severe osteoporosis, who you're looking at decades of treatment and probably sequential therapy, multiple vertebral fractures, for example, it may be reasonable to advocate for them getting anabolic therapy as first line. Again, mostly for PTH therapies, I'm thinking those patients who are at risk of vertebral fracture predominantly. And then romosozumab, actually I'm reviewing this, I'm like, oh, data's pretty good, but I haven't used it yet. I think I was reviewing use criteria. It is on formulary for Providence now, but you have to have failed denosumab, which we'll get to an important question at the end to get that covered. And then steroid-induced osteoporosis, I'd say I still use bisphosphonates like all the time for someone who's on chronic steroid use, but theoretically steroids inhibit osteoblast activity, and so that's one of the populations where it's recommended those be reasonable to consider. So this is looking at, and sequence does still matter. So this is a study that was looking at transitioning from denosumab to teriparatide, or teriparatide to denosumab, and also one of the arms shown in blue is the combination of using both at the same time, which we don't do. But basically what it shows on the lumbar spine is that so in red is teriparatide to denosumab, and clearly with transition you have continued gains in the bone density, and same with at the hip. And transitioning from denosumab to teriparatide, there were still gains at the spine with this little blip here, but there was a decline in the bone mineral density at the hip. So that was a little bit similar to what we saw in the structure trial, whereas the transition from bisphosphonate to teriparatide versus the structure. So we don't have fracture data, but it does seem like there's this little downtake in bone mineral density at the hip when we transition from an anti-resorptive to teriparatide. So for my patients who are at bigger risk of hip fracture, if I'm really worried about hip fracture, I'm probably not going to go that route. And so denosumab, again, to teriparatide, quick decline at the hip. So it's not recommended to do a direct transition between those two. And then contraindications to anabolic therapy. So for the PTH therapies, the big contraindications are related to risk of osteosarcoma, which is seen in rats. That's why the use is limited to 2 years. So if they have additional risk factors for osteosarcoma, that's a contraindication. And then romosozumab, there's a big FDA black box warning, cannot be used in someone who's had a stroke or a cardiovascular event within 12 months. And that's because, we'll look at a little bit of the data, but there were 2 major trials published in the New England Journal of Medicine, the FRAME and the ARCH trial. The ARCH trial was comparing romosozumab use to alendronate, and there did seem to be increased risk in cardiovascular or MACE events in the romosozumab arm. The rates were quite low, but this is what gave the FDA pause to approving the drug, and then they issued it with a black box warning. The FRAME study, which was comparing romosozumab to placebo, followed by denosumab, and both arms did not show a difference. So, and then all treatments must be followed by an anti-resorptive. So again, 24 months of use versus 12 months of use with the romosozumab. And what do we know about the transition? Again, everyone says start a bisphosphonate, but we need the data to actually show that that's beneficial. And so this was a study looking at transition of teriparatide to alendronate, and there was continued gains with that. And then again, teriparatide to denosumab did show continued gains in bone density, so that's reassuring. And then romosozumab, again, this was the ARCH trial, so this was romosozumab versus alendronate, and then for 1 year, and then everyone, alendronate continued on alendronate, and romosozumab was continued on alendronate. And this is looking at incidence of new vertebral fractures, and it showed that the risk ratio is 0.63 in the first year, and even a lower risk ratio or even greater benefit seen at 24 months after the transition to bisphosphonate. So this is actually fracture data suggesting that there's continued benefit having been exposed to romosozumab after transition to alendronate. And this is just looking at bone mineral density, since I showed all those images before, and it just shows the bone mineral density gain seen with romosozumab in the first 12 months persisted out to 3 years as compared to the alendronate group alone. And then again, the FRAME study was placebo versus romosozumab for 1 year, and then everybody transitioned to denosumab after 12 months. And this is looking at incidence vertebral fracture. Again, significant reduction in vertebral fracture, 73% as compared to placebo. And this was, there was even additional nominal risk reduction after transition, everyone transitioning to denosumab. So even though patients were now in denosumab, there's continued fracture reduction. And similarly, looking at bone density data, the bone density gains accrued initially persisted after transition of both groups to denosumab. So those all suggest that romosozumab followed by a bisphosphonate or denosumab seems to still have the benefit. So this is kind of a slide that Dr. McClung shared with me, just kind of long-term therapy. So usually we're starting out here, right? Bisphosphonate use. So after 3 to 5 years, you kind of should repeat your risk assessment. And someone who's at low risk, you could consider a drug holiday. And the perfect interval for monitoring bone density after drug holiday is not established, but would say around 2 to 3 years, of course, unless they have a clinical event. For those at high risk of therapy, it's appropriate to either continue therapy with the bisphosphonate or transition to another treatment. You can transition to denosumab, particularly if you're worried about the hip. You could consider romosozumab for 12 months. Particularly if they're at high risk of vertebral fracture, you could consider switching to anabolic. But again, the downtake in the bone mineral density at 6 months makes me a little nervous at the hip. All of these need to be either followed by a bisphosphonate or denosumab. And if you're considering stopping denosumab, you need to follow it up with a bisphosphonate as well. And when you should consider stopping denosumab, again, are we treating to a target T-score? That's still a little bit out there. So our patient ultimately transitioned to denosumab and remains on denosumab. And so just to review, we know the therapies are effective. They're effective early in treatment. They continue with prolonged treatment. The benefits decline after stopping treatment. They're overall low risk. Treatment failures defined as, so what do we do in the setting of treatment failure? So treatment failure would be defined as 2 new fragility fractures or 1 new fracture plus a decrease in bone mineral density. Second line options do include IV bisphosphonate, denosumab, PTHRP therapy, or romosozumab, and sequence does matter. So thank you. And then again, just the date to look out for, camera rounds 9/22. She's going to be talking about metabolic bone diseases and considerations for that. So, any questions?
We have about 5 minutes for questions.
I'll have about 20, but I'll
Yeah.
So did they continue the flex trial so that
Beyond 10 years?
beyond 10 years? Because
I don't know that off the top of my
they've
head,
been
yeah.
around long enough.
Oh, for sure. You mean you inherit patients
Maybe a
around
break
20
isn't something
years?
we've actually figured out
Yeah,
what
I'm
was-
not sure. Yeah, I haven't seen that.
And since you're buddies with Dr. McClung,
Mhm.
I never felt like I got a straight answer about one of his own studies, the HIP trial, looked at older patients who had relatively normal bone densities, and they did not benefit from treatment. Yet if you
Okay.
look at the
For
frac-
ondulendronate, yeah.
But if you look at the fracs,
Like the
model,
flex extension, yeah.
you know, you could argue that all of our 85 or 90-year-olds should be on treatment regardless of bone density.
Right,
So
yeah.
I feel like that study and the fracs are in conflict.
Yeah. I have to look specifically at that one. I'm not sure. I mean, my approach is typically, I haven't usually been using the fracs after, treatment has been initiated, just kind of an initial risk assessment. But for patients who have very low T-scores even after treatment, I would consider continuing, I guess. Yeah, or usually recommend continuing some sort of therapy. But typically my practice is now, if they've had 5 years bisphosphonate use, consider transition to denosumab at that point. But for the decreased risk of atypical femur fracture, the risks are still low, but we know that that's kind of where they're really starting to increase. And also just reviewing the FREEDOM trial showing there's additional benefit with prolonged use of denosumab that seems to exceed that of continuing bisphosphonates for 5 to 10 years. And also at the T-scores of the negative 1.5 and above. There's still a lot to be proven there, but that would be usually how I'm feeling. Yeah, I think they're probably getting additional benefit from switching to denosumab. Yeah.
Do you have a sense for who in the community is prescribing the denosumab? Is it like 80% endocrinologists and 20% PCPs, or 50-50, or hardly
Yeah,
any
I'm not
PCPs?
sure. I would guess just numbers wise it could be 50-50 just because there's so many more primary care providers. Obviously endocrinologists are using it a lot, and there are certainly, even within Providence, it seems to be very different from practice to practice. Even the PMG groups, some PMG groups are doing the denosumab themselves, and then others, when I'm doing these e-consults, it seems like they're not really set up to do it. But I think it would be appropriate for primary care providers to, incorporate that into the practice, and I think it's working well for the groups that are. Yeah.
Thank you.
Yeah.
If you have a patient who's not been previously diagnosed with osteoporosis, not on treatment, but presents with a fracture, do you follow the same treatment regimen with a bisphosphonate, or do you move immediately to a bone building drug?
I don't immediately go to a bone building drug. I usually think bisphosphonate. Bisphosphonates, like you said, they do offer very significant fracture reduction. If they have multiple vertebral fractures at onset, then I might give pause and consider, if it's a more dramatic presentation, but if it's a hip fracture or a single vertebral fracture, I still think bisphosphonate is very cost effective and also effective as for fracture reduction. So.
But in terms of the healing of the fracture?
Yeah, that's a controversial topic, but overall most studies have suggested that, the fracture reduction benefit it doesn't really play a huge role in healing, but usually I guess I'm not seeing them at the time of the hospital stay when they're getting fractured, so it's been a month or so, but obviously studies that have shown starting patients on treatment early has great benefit. So I don't say, they need to be on anabolic therapy for a little bit while they're healing from the fracture. That hasn't been my practice. Yeah. Can do.
And I think there's data on patients who have recent hip fracture being on bisphosphonates beneficial.
At the time of hospital stay, so.
Do you guys have a pathway on the east side of, because I feel like we had it at one point, do we? At least my hospitalist buddy.
We don't, we recommend it, but we don't have it.
Okay.
And I don't know actually inpatient, I never get those calls,
I
so.
know
Yeah.
was tried like 15 years ago, can we get a pathway?
Right.
Because people forget.
Exactly, yeah. And I think the clinical pharmacists within PMG have been really helpful as well. I know we work with one on the east side, and he often will coordinates the denosumab, things like that too. But in terms of, I have not been involved in the inpatient, implementing those protocols to make sure they're discharged on a medication after fracture. Would probably be beneficial, yeah.
Can you remind us, foot fractures, those don't count?
Those do not count, yeah.
But
And
ankle
often,
does.
but what?
But ankle does count.
We usually think of hip, spine, forearm, shoulder. I haven't really come across ankle so much. I guess it seems like a larger joint, so I might, but it's not one I think of as typically as a fragility fracture. And foot fractures, I'm worried much more about osteomalacia rather than osteoporosis. Yeah.
We're definitely at 9. Thanks so much.
Okay.